Who doesn't have HIV? Anybody?
Oh,
Okay. I'm sorry. I apologize for not handing it out in a more organized fashion. Who does not have HIV? Everybody does? These are extra?
They were Sammy's, so she gave them to you, so she took yours.
Yeah, I have.
But she's gonna bring it back.
Oh, yeah, I didn't know what we were doing.
She's just, okay, so, okay, sorry.
Just made copies. Oh, that's fine.
She's just gonna make a front copy of the,
Anybody?
for those who are on electronic. Okay, so let's move Sammy's back down here. So while I'm talking, she'll be back down. So electronically, I uploaded my form before I finished your objectives, so she's gonna make copies and bring those down for those of you who'd like to follow along the objectives that are electronic. Okay, who doesn't have the one-page anti-helmintics? 2, so can we pass those back? Everybody else have the one page? Okay, everybody have an amphotericin B? Okay, we're good. Okay, if you, so these are 3, we've just got 3 things put together. So the objectives for the HIV are pretty much like my old, very generic, because I stripped this thing down to the point where I'm just telling you everything is important, everything is testable, except there are a few things I'll just tell you as we go through, I'm not going to test you on, okay? I didn't write any for the anti-helmintics because it's half a page, it's everything, there's not that much to say. And amphotericin B are more like my usual. If at the end you really want more specific, I'll do them, but I don't think it's necessary. But I will if that's kind of consensus. For question-wise, I will probably submit winter test.
Monday.
Oh, okay. So I will probably submit 10 to 12. We'll send that out, make sure, but since there's 3, I'll probably do 1 or 2 over the worms, probably up to 4 on the amphotericin B and 6 or so on the HIV. Okay, then it makes it worth your while. Okay. Questions then? Okay, well, I'm waiting for her. I don't think it'll take us all the 2 hours. We'll just see where we are at the usual break time and we'll decide. I'll give you an update on how long I think I need. Any questions on the prescriptions? The most questions I've gotten are over, again, your new and renewal status. I gave it to you in the very first module, your laws. I have posted them to D2L in the past. When I sent out these prescription sets, I sent you the laws again. You need to read those and use that as your guide for writing your renewal, your refills. That's probably the place you all mostly don't know what to do is at this point that I see. For the most part, you get the rest of it correct. Nothing else? Everybody's coming along well with it then? You've got till the end of the month. If you're struggling with it, then let me know. Okay. I hope she's not making a full sheet of those. Well, let's just start with the worms. Everybody has the worms, so let's just do those first. There's really not a lot for you to know here that in addition to what you've already learned. But these are the ones that are most commonly available. The one you'll probably use the most is in the middle there. Albendazole. It's for pinworm, roundworm, probably the most common. There are others available, but you have to go to the CDC to get them. Okay. So this one, easy to write for. The good part is that most of these are one-time doses. Usually kid dose and adult dose are the same. They're all oral. And they're very effective. So ivermectin, you may remember when we did scabies, remember? We talked about ivermectin back then. So it's a neurotoxin, very effective. It kills the muscle cells and the nerve cells in the parasite, and they die very quickly. It's a one-time dose, or you can give it over 2 days, but it's very short term. The thing to remember to stand out about this one is that for kids, it's 15 kilograms and older. There's just no data, so it may be used I'm saying in practice people may use it, but there is no data, and the recommendations from the manufacturer are not to use it in kids under 15 kilos. Breastfeeding and pregnancy, it's recommended you use something else. In the world at large, the World Health Organization has come out and said you can use albendazole in later pregnancies when you have big outbreaks. But in this country, we don't see that. So for the most part, just put it into the do not use in pregnancy and breastfeeding. All of these, because they're usually one-time doses, are well tolerated. They're not going to hang around long enough for most people to have problems. So they're usually non-specific, so itching, rash may occur, joint pain, fevers, but that's about it. Otherwise, well tolerated. Albendazole is, it's an interesting drug in that it just starves the worm to death. So it cuts off its ability to use glucose. Eventually, the parasite dies because it no longer can produce energy to live. So that's its mechanism of action. The dose here will depend on the worm. So if you're looking at roundworm or pinworm, which are more common, then those are usually 1 dose. Thank you. Who?
The HIV agenda?
Yeah, we just needed the front page, sorry. Here. These, let's see, Allison, thank you very much for doing that, I appreciate it. Who else? Thank you for sharing. Who else? Nobody else? Okay, I'll leave them here on the side, you can pick them up. Okay, so for the roundworm, it's 1 dose. Kids, it's the same. Pinworm, it's 1 dose and repeat in 2 weeks. And then the tapeworm is a much longer treatment. Have y'all had this already? Have you seen all those? You haven't had the worms yet?
Oh, we got the word.
Aren't they gross? They're just gross. I always think that's where in Star Wars they got, or not Star Wars, but in Star Trek, they mostly get the places where, you know, they put the organisms in there to test their brain and then to make them talk. It's probably come because of based on worms and these parasites. Absorption here is improved with a fatty meal, so you want to have them take it with food. Again, side effects are low, but it might upset their stomach, so nausea and vomiting. Liver enzymes, usually you're going to see that with longer term therapy instead of short term. Praziquantel is used mostly for schistosomiasis in this country. It is another neurotoxin. The organism just eventually can't function because of loss of neural integrity. Again, this one is an interesting dose, but it's done in 1 day. So you've got a dose based on weight. It's given 3 times in the day, 4 to 6 hours apart, all done in 1 day. Again, side effects, so you do have some CNS side effects and GI upset. Those are the things to take away from those. Questions on the worm medicine? Okay. So I don't care what we do next. What are you most interested in? Amphotericin B or the HIV? HIV, okay. It's a good thing it's near the end of the year because you all have not much further back to go in the classroom, so. Okay, HIV. What I have done here is I have really just focused on drug. I'm not going to talk about how treatment is done because most of you will never do that unless you are specializing in infectious disease, and that would be in HIV treatment. You're not going to start these drugs. You're not going to change these drugs. Mostly what you'll see them through is primary care, and you're likely to have contact with patients who are on these medications. So more what I want you to concentrate on are what the objectives are looking at, and that's their mechanism of action, what drug belongs in what class, so you should be able to tell one of the four. There are about 25 to 30 of these on the market. I have stripped it down to 2 or 3 in each class. They're the most common ones used. Okay? There are no brand names with these either because they all come in, we always give them in groups of 3 or 4. And there are combination products on the market. So there will be a drug like Complera who has 3 different ingredients, okay? So you don't see them stand alone. You're always going to use them together. There is no such thing as monotherapy with HIV. If you can kind of borrow from what the approaches we took with hepatitis C, it was the same thing. We never used monotherapy with hepatitis C, right? So when we're dealing with a virus, we rarely use one drug because it mutates too fast. And here is the problem with HIV. In the past, it was a major problem. Nowadays, our drugs are more stable. They've done better with the combinations, and so resistance and genetic resistance is usually higher, so we don't see as much resistance creeping in. So I want you to know the mechanisms of the class. I want you to know the big side effects because you more likely see that. We're going to spend time on monitoring and complications of therapy because that's where I tended to see them in primary care was the complications. Some of these drugs, especially the protease inhibitors, cause a lot of glucose intolerance. So I saw a fair number of people with HIV infections who also had developed diabetes secondary to the disease. Their cardiovascular risk is higher, so you may see them because of that in primary care, or that will be designated to you to do or to treat. We're going to talk about prophylaxis with PrEP, so I want you to know those as well. So those are the big things, and that's mostly what I've stripped the handout down to. So you've had your HIV lecture, yes? Okay, so what did you take away from there?
Very complicated to treat.
Very complicated to treat. That's why it needs a specialty. The number one thing I would say I dealt with in primary care is adherence. And adherence is extremely important. Taking the drug every day and at a designated time is really important to keep viral load down and to maintain a zero or non-detectable viral count and to keep their CD4 levels up. What else have you learned? Yes.
We used to mainly start treatments after the disease had kind of progressed further, mainly due to the costs of the drugs, but now they're starting them like right away.
Right, everybody can get, so everybody it's recommended everybody be treated now, that's true. They're expensive, but you can get access. There are the Ryan White Foundation provides lots of money for patients to get their drugs. So I don't see barriers to people getting the drugs, yes.
I was wondering, but I didn't ask the lecturer yesterday, for instance, because they have the combination drugs that come 3 in 1. Is it where these drugs have a generic form, where giving them like the 3 individually would be less expensive than the combination drug?
I don't know of any generics of the preferred that are out there. Could be, I don't know that that's the case though.
Okay.
What else?
Predisposes to atypical infections.
Yes, very atypical. So you may see those, particularly if you're in the hospital, you may see some really odd ones. We talked about some of those when we were in pulmonology. Those atypical pneumonias are very common in or immunosuppressed, more fungal type of pneumonias or systemic fungal infections as well. What else have you learned? So in your lifetime, the HIV and AIDS to me has changed dramatically. So I lived in Austin when they first started putting the puzzle together. And we had a huge gay population. And I remember the day that the physicians came in and said, here's what's going on. Here is, and I saw a lot of these, in the hospital we had a lot of people with HIV infections, staff. So I saw these people just die. It was a death sentence. So this was the early 80s. And they came in and they said, here's what's happening. They laid it out. Here's how we have tracked it. Here's what we're naming it. Here's what it is. Here's how it presents. And here's what we have to treat it with. And we didn't have much. We had zidovudine, we had pentamidine, and we had trimsulfa. That was it. And most of those folks died very quickly. It's because they would present with advanced immunosuppression. So that was the case for probably 5 to 10 years until Magic Johnson. Do you all know who that is? Okay. So in 1991 he came out and he said, I have AIDS. I think he said AIDS. I don't remember him saying. Most of the time you'll hear older practitioners refer to as an AIDS because that's what we saw. We saw the end result. And now we deal mostly with people who have HIV infection, and AIDS is a terminology we use for very advanced disease. So he came out in 91 and said, I'm leaving the MBA and I have AIDS. Look at him, 26 years. That is amazing, amazing. Good care, he can afford good care, and he's taken his drugs. So that has kept him alive for a long time. So I don't know that you all have the same reaction when you hear about people with HIV infections that I do, because it was a very fatal disease when I was in your shoes. So tell me about that. Tell me, in terms of HIV, is it just something you've grown up with, or how do you even think about it?
I think I was like introduced to it from that, like, this is a fatal disease concept, that I never thought it was like not a big deal. But we also have been around when the new drugs have come out and better treatments have come out. So that was something we talked about yesterday, was that survival rates are much better and people don't progress to AIDS nearly as much, especially in the US.
Right.
But I still think it was like the big scary thing when I first heard about it.
But people were scared. They were scared to interact with them. They were scared to, it got to where first responders didn't necessarily want to resuscitate people because they didn't know the risk. The blood supply was tainted, so women got transfusions and ended up with AIDS and passed it on to their children. Some of the early activists were in that category and had children then with AIDS, died early and left their kids. And so some of them went to Magic Johnson and said, you have got to become the face of this. You have got to get out there and tell people your story and promote it, because people know you and they'll listen to you. And so he did that, to his credit. So I don't sense the fear anymore that people have that was fairly rampant early on. People were deathly afraid of getting AIDS because there wasn't much hope for treatment at that time. Okay, anything else that you know? Yes?
I think it's interesting though, some of the younger people, like, they don't understand the risks associated with the lifestyle that they choose. And
okay.
so I feel like a lot of people in our society, we talked about this a little bit, but it'll never happen to me, kind of, so they never get tested, like all those kinds of things. So I thought that was just an interesting topic.
That's another role you will play, in that it is always talking prevention. Because we can treat you and keep you alive, but we really would like you not to spread it to other people. So that promotion of the public health also falls into your realm, bringing it up with people, especially people who engage in very high-risk behaviors in terms of either sexual behavior or needle sharing or in their drug use. All right, so let's look on the second page. So you talked about the concept of antiretroviral therapy, I'm assuming, and we call it ART. So our main goals here is that we want to treat the infection, but we want to also keep the virus from multiplying in a person's body and producing disease, and we want to keep them from transmitting it to other people. So those are our big goals. You know that it cannot be cured. I saw something just recently that said it probably never will be cured, but we can manage it. And so that many things go into that in terms of reducing transmission and identifying people early in treating and helping patients to understand. I dealt with a population that I've told you before is very low socioeconomic, very low resource. The thing that I found most was drop in adherence. They would lose their place to live, and so then everything falls apart. And so they're continuing to take medications was difficult. Going back to the doctor maybe was difficult. So I did a lot of adherence work. Let's get you back in, let's get you reconnected. What happened? Why did you fall out of care? A lot of addressing of social problems that get in the way. Goals of therapy, under the second major heading, reduce morbidity and mortality, keep you alive, keep you healthy, keep you doing what you want to do. Maximal suppression of that HIV RNA, so I assume you all talked about that, the monitoring of it, when to do that and how often to do it, when to repeat it. Not something maybe you would do, but maybe engaging patients and getting that information from them when you see them. The other is reducing the risk of disease-resistant mutations. So when patients don't take their medicine, then resistance comes up. Okay, so we'd like to keep the medicines that we have usable and have to decrease the flow of how many new drugs we have to have. Okay, so those are all important goals. Who do you treat? Everyone, all HIV-infected patients, asymptomatic, regardless of immune. They have great immune status. Well, they won't over time. So everyone would be treated. We're going to talk about 4 of the big classes. We're going to talk about the NRTIs, or the nucleoside reverse transcriptase inhibitors. Those are the backbone of therapy. Every regimen that somebody is on will have them, and usually they'll have 2 of them in a regimen. So those are your foundation pieces. We'll also talk about the RTIs, which is starts on page 4, the non-nucleoside reverse transcriptase inhibitors. These are only active against HIV-1, so they're part of a regimen, but they will never be the strength in a regimen. Then we have the protease inhibitors and the integrase strand transfer inhibitors. So we're going to go through those 4 groups. So the nucleoside transcriptase inhibitors, there's 4 drugs in this class that I want you to know. They each are a analog of one of the nucleotide bases. So like guanosine and cytosine, adenosine. So their job is to undergo phosphorylation intracellularly. So these are usually prodrugs that have to get into the cell. They are metabolized, or they're metabolized, converted into the active drug, and then that's where they exert their effect. So these are all going to stop viral replication. They have very good spectrum of activity. They are good against HIV-1 and HIV-2. Did you all talk about mitochondrial toxicity?
I don't think so.
It's probably the only place you'll ever see this listed as a side effect. So this is the toxicities associated with this class of drugs. And it usually manifests as listed there under that first bullet. So peripheral neuropathies, pancreatitis, lipoatrophy, and hepatic steatosis. So they all carry a black box warning for this. However, the newer agents are less likely to do this. So we don't see great numbers of people with these side effects, but they are they are present in that class. So older members would have this. But the commonly used ones, and those 4 are listed there for you. Tenofovir has 2 different salts. We never use them together. They're always used separately. They have some advantages over each other. Abacavir, emtricitabine, and lamivudine. Sorry, I don't say these words every day, so lamivudine. Okay. Drug interactions. So I'll just tell you, put it in your brain that anytime you see a patient on HIV antiretrovirals, always look up your drug interactions if you are going to prescribe a medication. Some of them have very insignificant roles in terms of interacting with other drugs, but most of them have some impact on the 3A4 system, and that's the big one. So always look it up. Always run it through your interactions checker. Your Hippocrates has one, and see what pops up. If you don't know where to go from there, then call your pharmacy and ask them what they recommend. Let's see. The only one under drug interactions under this class is with tenofovir, and that is with rifamycins. Okay, that's important because these folks often have other viral diseases that they are also dealing with, or TB. Okay, so TB, HIV, common. Also Hep C. Okay, some of these drugs will activate their Hep C, or make it more likely that they'll have it if they have a inactive disease. So keep that one in mind. Okay. Questions or comments? If I say things different from, who came and talked to you? Lupta? Then please raise that in class. I don't mind. She has done it. She did it for years. So common agents on the next page. Tenofovir is a nucleotide analog of adenosine. This is one of the preferred of this class. This is probably one of the most common ones you'll see. 2 different salts. So you have tenofovir, disoproxyl fumarate, that's TDF. You'll see it designated as that. A prodrug. Also the other one, the alafenamide, is TAF. Both of these prodrugs. Okay. So again, never going to give them together, but one of them. So let's look at TDF first. Taken daily without regard to food. So if you are dealing with people who are having to take these drugs, some of them have to be taken with food, some of them have to be taken on empty stomach. So if you're ever having to deal with something that would affect their food intake or their mealtime intake, think about that as a factor that needs to be considered if you're moving drugs or changing drugs or adding drugs, or people aren't eating. This one is almost always combined with emtricitabine. Okay, so you'll see these 2 together all the time. In fact, that combination is the one we use to prophylax people who have high risk of getting infected with the HIV virus. They will always be combined with a 3rd agent, always. So 2 NRTIs will always have a 3rd. They'll either have a protease added or they'll have one of the integrase transfer agents added to them. The 2 big side effects to worry about are kidney injury and bone loss. So you'll want to know baseline, what is their kidney status, and then you will have periodic monitoring. I think they're recommended like every 3 to 6 months for these agents. If you're dealing with a woman, and so you would be wanting to look at baseline bone mineral density, and then following that if they're on that drug long term. Let's look at TAF. So this introduces another concept using pharmacologic boosters. Did you all talk about that yesterday? Okay. Remember when we talked about hepatitis C, we had some drugs that we would use with ritonavir? Okay. So ritonavir is a protease inhibitor, and it has activity against viruses, but its toxicity is too high, so we don't use it anymore. We used to use it for hep C. We don't use it anymore because other drugs have come along that are easier to tolerate. But what it does is it can inhibit the metabolism of other antivirals. It boosts their serum concentrations for longer periods of time and allows for us to dose the drug less often and keep levels up for longer periods of time. So that's what a pharmacologic booster is. There's two of them that are used in antiretroviral regimens. And the other one is Cosivastat, which is written down there. And we're going to talk about that in depth in a little bit. I want you to know which drugs require a booster and which don't. I want you to be able to explain to me, why do we use boosters? What are they there for? Because Cosivastat has no antiviral activity. It is simply there to affect other drug in that regimen. Ritonavir has antiviral activity, but we use it in such a low dose it would not be effective. Okay? So start when we come to it. It's an important concept I want you to know and recognize in a regimen that's what that piece is for. TAF has advantages over TDF in that it is less renal, less toxicity, so preferred, more expensive. Okay, questions about those? Have y'all been in class all day? I love 3 o'clock. Okay, abacavir. Sometimes people call it ABC as well. So abacavir is a guanosine, so a different nucleoside. So you could use this with tenofovir because they are going after different nucleotides. Always used in combination with another NRTI and a third agent. Again, the protease inhibitors or the integrase strand transfer agents. Okay, this one's important, so make a mark by it, is you need to do testing. If you are going to use this, then you need to do an HLA 5701 test. Okay? We've done this before. What other drugs do we do those HLA testings on? Allopurinol, I saw somebody mouth. What else? I've written them down there. Carbamazepine. Okay. So, HLA, what's the HLA all about? Part of the major histocompatibility groups. It's the way our body recognizes self from non-self, discriminates. Okay? So when these drugs interact with this HLA part of the major histability complex, they change it in a way that makes the immune system look at it as non-self. So these drugs, if you give these drugs, like with allopurinol, carbamazepine, if you give these drugs to people that have that HLA group, then you will cause severe hypersensitivity reactions. They can be fatal. So remember with allopurinol, we talked about with the Han Chinese and with the Thai and Korean, high incidence of having these particular genetic expressions. So that's why for this drug, if you're going to use it, you test everybody, okay, to see if they have that HLA antigen. Make sense? Okay. So clinical syndromes, and it's given a name, abacavir hypersensitivity reaction, AHR. You may see it in AIDS or in HIV literature. So the symptoms are fever, malaise, dizziness, headache, GI, respiratory symptoms, rash. So very nonspecific, but can progress to a very acute situation, and the person can die from it. If it is noted, or if it's detected or diagnosed, then discontinuing and providing supportive care is what is recommended. One other thing to kind of star is is to avoid this drug in coronary artery disease. When we get to monitoring, we're going to talk about one of the complications. And it's really, we're not sure if it's the disease, if it's the drugs, but patients with HIV infections tend to have a higher risk for coronary artery disease. So this would be a drug to avoid. There's other ones to use, but it increase the risk. They have higher blood pressure, higher lipids, more likely to get diabetes. So looking at cardiovascular risk is important for these folks. Questions about these? So on the top of the next page, lamivudine and emtricitabine, these are cytosine analogs, both of them. They're considered to be interchangeable. You would never use them together because they go after the same intracellular enzyme systems, and so they would interfere with each other. Okay, so one or the other. You tend to see the emtricitabine much more often than you do the lamivudine. Let's see. Pancreatitis is more associated with lamivudine, but it is low. It's a very low percentage. And then the skin hyperpigmentation on the sole and the palms of the hands and feet. Yeah, it's not known that it's noted. It is not thought to be dangerous or worrisome. It's just it's a side effect that happens. Kind of like the amiodarone discoloration. Not really much we do about it. Patients don't like to look gray, blue, but we don't think it is associated with any more untoward effect than that. I put the combination therapy down there just to remind you these are always in combination, always. 3 or 4 different agents put together. Question or comment about the NRTIs? Okay, let's look at the non-nucleoside reverse transcriptase inhibitors. There's 3 in this class. They work to inhibit the growing a DNA chain. So they have a little bit different effect than the nucleoside reverse transcriptase inhibitors. They also decrease viral replication. They are only effective against HIV-1, so not quite as potent as the rest that we're going to talk about. All the rest hit both HIV-1 and HIV-2. They're always given in combinations, usually with an NRTI as well. They have very long half-lives, so that allows us to dose once a day. Almost, I can't think of any that are not dosed once a day. But we've moved all to where it's once a day to improve adherence. And then it's the combination of drugs in one pill, again, to improve adherence. Favorance is what to keep in mind. Well, let's just look at the 3. There's rilpivirine, there's rilpivirine, and then traverine. Those are the 3 in this category. The first one, favorance, is teratogenic. So keep that. That's a difference with that one. So neural tube defects are the problem. So it's early in pregnancy. It's the first 8 weeks. Can be used later, but it's during that time of organ development that we want to avoid it. CNS are the problems here, psych and central nervous system, so the confusion, dizziness, headaches, insomnia, mood swings, increased suicide risk is associated with them. Rilpivirine is QTC prolongation. This one, note that it should not be used with a proton pump inhibitor. So very common in our society, lots of people use them. Keeping that one in mind is important. Again, you're going to see the rapamycins and the antiepileptics. That's common for most of the interactions are going to be with the rapamycins or with the anticonvulsants. Think about those and I told you when we went through, we talked about seizures, whenever you see an antiepileptic, always think drug interactions. They are huge, usually modulators of the P450 system. They either serve as a substrate, so they get in the way of other drugs being metabolized. They rev up the system so that everything gets metabolized faster, or they stop it so that nothing gets metabolized very fast. Okay, so they're incredibly interactive with that system. Always, always think drug interactions with them. The last one, Trevorine. This one is used more if people have drug-resistant viruses. So when people are diagnosed, they usually will do they'll run a test on the virus, and they'll look for where the drug resistance is. So it's got to be a lot like what we do with cancer. We will look at the virus, we'll look at what it's susceptible to, and match up the drugs. You can even see drug resistance in people who are treatment naive. So patients who have been treated and who have developed resistance can transfer that resistance to someone else when they infect them. Another reason to promote good behaviors that decrease transmission. The important one with this is, again, hypersensitivity reactions, but it isn't like what we see with efavirenz. It is more like the Stevens-Johnson's or the TEN, the severe hypersensitivity reactions. Questions about those? Okay, why don't you get up and move around? Let's go ahead and take a break. Y'all are really tired looking at it.